Dr. Ramara Walker. Hi, there you go. Dr. Walker is a native of Cleveland, Ohio, is currently the infectious diseases clinical pharmacy specialist at Cleveland Clinic. She received her undergraduate and PharmD degrees, both at the Ohio State University. Go Buckeyes. And she completed her postgraduate residencies at Cleveland Clinic and the VA Northeast Ohio Medical Center. Her current specialty and research interests within infectious disease include HIV PrEP, community-acquired pneumonia, and health equity. And as a result, for her passion for health equity, Dr. Walker has also developed and served as the chairperson for the Health Equity Antimicrobial Stewardship Task Force at Cleveland Clinic main campus. And it is my honor to introduce Dr. Walker.
I just want to start by saying it is a honor and a privilege to be here. I know that I am standing in between lunch and we are a little bit over, so I'm going to go as fast as I can, but not dilute the message. All right. So I do not have any disclosures. Let me keep going. Okay, here we go. At the end of this presentation, you'll be able to define health equity, the principle of pharmacoequity as well, analyze literature evaluating health disparities and antimicrobial use, and identify methods to implement health equity efforts in your respective institutions. So I think for a health equity talk, it's critical to define health equity, and I'd like to do this by comparing and contrasting equality and equity. So the CDC actually states that health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. So I want to use this illustration here to kind of explain that a little bit more. So in the top, we'll see a person with a disability, a man kind of hunched over, a woman and a child, and they have all received a bicycle. So equality says that everyone gets the same, regardless if it's needed or right for you. But when we look deeper and dive into equity, we now see that everyone is actually able to enjoy the bike that they were given. And equity says everyone gets what they need, and this takes into consideration individualized barriers, conditions, and circumstances. So if we are going to try to reach for a future desired state of health equity, it is going to be critical that there are ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and then eliminate preventable health disparities. But on our journey to achieving health equity, we have to encompass and think about pharmacoequity as well. And this term was actually coined by Dr. Essien, and he says that pharmacoequity is ensuring that all individuals, regardless of their race, ethnicity, socioeconomic status, and availability of resources, have access to the highest quality medications that are required to manage their health needs. So most recently, I think we're all aware of the COVID-19 pandemic, and this pandemic revealed substantial inequities in access to life-saving treatments for COVID-19, particularly with our African-American community, as they died the most from COVID-19. So on this journey and throughout the rest of my presentation, I'll kind of point out in some of the studies that we'll review if there were like a pharmacoequity issue, and how we can really evaluate our medical treatments as well. So now that we kind of understand the differences between equality, equity, as well as pharmacoequity, I want to talk about initiatives that have been around actually for decades, and what our country is doing to try to advance to a state of health equity. So the first initiative, and the main one I'll talk about today, is Healthy People. So Healthy People was actually started in 1979 by Surgeon General Julius Richard, and he issued this landmark report titled Healthy People, Surgeon General Report on Health Promotion and Disease Prevention. Healthy People 2030 is actually the 5th iteration of this initiative. And it builds upon the knowledge that we've gained over the years and the lessons that we've learned to try to address the latest public health priorities. So the vision of Healthy People 2030 is a society in which people can achieve their full potential for health and well-being across the lifespan. And the mission is to promote, strengthen, and evaluate the nation's efforts to improve health and well-being of all people. So I bring up Healthy People 2030 because a major key focus of this initiative is looking deeper into social determinants of health. So I want to review what these are, and they are essentially conditions that affect our health and quality of life, and they have been grouped into 5 domains. So these are not presented in any particular order, but I'll go through them and their importance. So the first is economic stability. 1 in 10 Americans live in poverty. Therefore, they're more concerned about how can I afford food on my table? What clothes am I going to wear? Do I have stable housing and a place to stay? So when we think about that, they're not concerned about healthcare, making appointments, and any of that, because there are other necessities that they are concerned and worried about. So the goal is to help more people achieve economic stability. The second domain is healthcare access and quality. Similarly, 1 in 10 Americans lack insurance coverage. These Americans are less likely to have a primary care physician. They're not going to receive preventative screenings that can be life-saving. And they also, sorry about that. See, I can scroll down. They also won't be able to afford healthcare services or their medications. And we know that Americans as they age have chronic illnesses and disease states that are managed with medications. So without that access, we're seeing issues as well. So the goal here is to increase comprehensive and high quality healthcare access. The third domain says for social and community context, that relationships matter, right? So the relationships and interactions that you have with your family members, your friends, your coworkers, and your community members matter and can have an impact on your health. So when we think of folks that may live in unsafe neighborhoods or people that experience discrimination in any type of context, and even bullying for some of our adolescents and our children, all of these are just a few examples of things that can have negative impact on your health. So we want to promote increasing positive social and community support. The fourth is education, access, and quality. And this essentially says that those that have higher levels of higher levels of education go on to lead healthier lives because they know that it's important to eat healthy and exercise and how that impacts them. But they also have access to higher paying quality jobs as well as a result of this education. So based off of this, the goal is to increase educational opportunities as well as ensuring that our youth and adolescents are performing well in school. And then the fifth domain is surrounding the neighborhood and built environment. So this essentially says that where you live can have an impact on your health as well. So unfortunately, there are numerous neighborhoods across the United States that are riddled with high rates of crime and violence, but also air and water pollution and other health safety risks. So we know that racially and ethnically minoritized patients with lower incomes typically live in these type of neighborhoods. So the goal here is to increase safe and healthy neighborhoods where people are able to essentially, be safe. So it's kind of the goal there that they're working on for that fifth domain. Okay, so I spent a lot of time on the social determinants of health. They are quite important because there's been an association between these factors and patient health outcomes. And I essentially want to kind of look at our current state of health inequity and figure out what steps we can take to reach our future desired state of health equity. And I'm going to do this by sharing a quick parable or a little story that was written by medical sociologist Irving Zola. And in this parable, there was a man that approached a riverbank and noticed a person was drowning. He attempted to save the drowning person, but then noticed that there were additional people in the riverbank drowning. After unsuccessfully trying to save everyone from drowning, he realized that I'm going to go walk upstream of this riverbank and try to figure out kind of what this root cause is. Like, why are these people drowning? So in the same sense, when we think about the steps and the interventions that we could take to reach a future state of health equity, not all of our interventions may have the same impact. Some of them impact our patients on an individual level. So that's if they're coming into appointments, seeing their primary care physicians, those of us that work in antimicrobial stewardship or infectious diseases, completing reviews, prospective audit and feedback, you're having that individualized impact. If we want to impact the community and have more community level interventions, we'll have to address health-related social needs. So that's connecting the individual to social services and assistance programs that may be able to help that community. But ultimately, we're going to have to change our governmental policies. And this will happen at the local, the state, and the national legislation change. So quickly now, I'll go into 3 studies very much as quickly as possible that kind of just highlight that there are health disparities even within antimicrobial stewardship. So this first study was conducted by Worso and colleagues, and they looked at the variation by race in antibiotics prescribed for hospitalized patients with skin and soft tissue infections. So the data came from the National Survey of Acute Care Hospital Groups from Vizient. And this survey, or the study was conducted from October 2018 to January 2019. And there were a little bit over 1,000 participants that they evaluated. There were a few racial groups that were excluded from comparison due to low sample sizes. So this left 224 participants in our Black group and 854 participants in the white group. Their primary outcome was looking at antibiotic use amongst patients with SSTIs, and I'll just quickly review their table 2 here. So in general, overall, majority of patients actually received vancomycin or pip/tazo, and there was no difference seen amongst the groups there. But when we look at cefazolin here, white patients were 2.82 times more likely to receive cefazolin than our Black patients, and this was statistically significant with the p-value of 0.003. And then when we look at clindamycin, we see that our Black patients were more likely to receive clindamycin than our white patients, also statistically significant. And this was after controlling for MRSA colonization, infection, as well as penicillin allergies. So this study essentially demonstrated that Black race was associated with increased clindamycin use for our skin and soft tissue infections, which we know is a suboptimal agent to treat that. So that kind of warrants taking a deeper look and understanding with research projects, like, why is this happening? If we don't understand the why, then we can't address the issue, and then we can't prevent or reduce the disparities that we're seeing. The second study here by McLeod and colleagues, they examined race and social vulnerability disparities in outpatient treatment of uncomplicated cystitis. So adult patients with cystitis who received treatment from an ED or urgent care center at Loma Linda during that 4-month study period were included. A few key definitions here would be those who were racially and ethnically minoritized. So those are patients identifying as Black, Asian, Middle Eastern, Hispanic, or Latin. And then for those that identified as white, they were non-REM, essentially. So there were 187 patients in total. Majority of the patients belonged to the REM group that were minoritized. And then we see 73 patients in the N-REM group. So for the results here, I'm sure it's pretty small on the screen. E. coli and Klebsiella were the most common urinary pathogens isolated, so that's not to be unexpected there. They also saw that there was pharmacoequity. So the oral discharge antibiotics most frequently prescribed amongst both groups were cephalexin and nitrofurantoin. And that is in line with our national guidelines as well. But we begin to see some differences in our socio-demographic data here. So REM patients were significantly younger than our non-REM patients. So they're presenting at a median age of 47 versus 67. Our REM patients were also significantly more likely to have the highest level of social vulnerability than non-REM patients. And that was statistically significant. So that's kind of digging back and looking at those social determinants of health and seeing higher levels of disadvantage in the minoritized patients. And then finally, REM patients were less likely to have documented susceptibility, and they were more likely to have documented resistance to the agents prescribed on discharge. So this should have us kind of begin to question, why is it that our REM patients are receiving the first line therapy, either cephalexin or nitrofurantoin for a UTI, but they have greater documented resistance? So what are some factors that could be contributing to that? And we're seeing that the CDC has actually stated there may be a tie to social determinants of health and antimicrobial resistance. And this is just warranting further research into that. And then the very last study, very quickly here, for anyone who may work with our pediatric population, Erickson and colleagues looked at the burden of invasive Staph aureus infections in our hospitalized infants. So they were infant patients with an invasive Staph aureus infection that was discharged from 348 NICUs. And this study took place from 1997 to 2012. Some key definitions here. An invasive infection was defined as a positive culture that came from CSF, blood, sterile fluid, or an abscess. And then for the sake of time, there was 3,888 patients, and majority of them belonged to the MSSA group. So that's good to see that there were more patients in that group than MRSA. But for some of the results here, interestingly, the study authors found that infants who were of African-American race, born at another hospital and then transferred or outborn, as they termed it, or had a younger postnatal age, they had a greater proportion of Staph aureus infections that were MRSA than MSSA. They also found that death before hospital discharge occurred more in infants with invasive Staph aureus infections that had a very low birth weight. So that's probably not to be unexpected there, and that was statistically significant. And then very small down there, and they also looked at the annual incidence of Staph aureus infections. And the only thing I wanted to kind of point out from this figure is that the incidence of invasive Staph aureus infections increased from 1997 to about 2006. And then we see about in 2007, the overall incidence started to decrease, and they attributed that to better infection prevention measures. So that's great to see there. But the reason I included this study is just to show that we should be questioning and trying to dig deeper into why there potentially could be a racial disparity when it comes to invasive Staph aureus infections in our infant patient population and what factors are associated with that. So finally, trying to see how I'm doing on time, I'm just going to go through a few steps that I personally took after digging more into health equity and trying to figure out how I could be part of the solution in my job at Cleveland Clinic. I developed a pharmacist-led health equity antimicrobial stewardship task force, and I'll review some of the Joint Commission requirements surrounding health equity, as well as kind of what the CDC is saying about their priority with antimicrobial resistance and health equity as well. So the first step that I did and would recommend is to identify at your institution who the executive director of health equity is. And they may have a different title, a different name, but the reason that this is recommended as the first step is because in January 1st of 2023, the Joint Commission actually has new requirements to reduce healthcare disparities. And these will apply to organizations in ambulatory healthcare, behavioral health, critical access hospitals, and hospitals as well. They released 6 new elements of performance to address healthcare disparities as a quality and safety priority. And this is particularly regarding leadership And the first element actually says that the organization should designate individuals to lead activities to reduce healthcare disparities. So there should be someone or a group of people that are in charge of this initiative. So after you identify who that is or who that group is, I recommend assessing your baseline data for your hospital. And I did this, and I just wanted to share 4 key takeaways from my meeting with the executive director at Cleveland Clinic and Health Equity. Cleveland Clinic in the last few years has assessed for differences in race by readmission rates, mortality, specifically with sepsis and septic shock, as well as preterm birth rates and C-section rates. And what they essentially found higher 30-day all-cause readmission rates for Black patients than white patients from 2020 to 2023. They found similar incidents of severe sepsis and septic shock amongst both Black and white patients, but they did find higher preterm birth rates and higher C-section rates in our Black mothers than our white mothers. So this allowed me to kind of assess what my institution was looking into and what specifically their initiatives might be based off of some of these disparities that they found. So the next step would be to identify research gaps based off of that baseline data. And this is the opportunity to where you can either dig into infectious diseases, antimicrobial stewardship, and health equity if it's not a focus of your institution, or you can partner with your institution on whichever health disparity they have identified as a focus for the year. So I do want to mention that the CDC is prioritizing health equity related to antimicrobial resistance. And this is because many risks for antimicrobial resistance are tied to those social determinants of health, but more research is needed in this area. I would argue that health equity research is still needed in all areas and that you can consider studying C. diff, invasive candidiasis, salmonella, and shigella if you work with our pediatric patient population, as our children younger than 5 are at increased risk there, HIV and PrEP if you're in that space, as well as COVID. Next, it will be critical to identify key stakeholders to join your task force. So a few that I have partnered with at Cleveland Clinic would be my infectious diseases medical staff, so the chair of ID getting their buy-in, clinical pharmacists, other ID pharmacists, as well as the director of pharmacy, and making that a priority for the year. Infection prevention and control, I think a lot of us in this room, or many of you in this room work specifically in that area, but also microbiology, nursing. And I also write here the Office of Diversity, Equity, and Inclusion, if you have that available. And the reason being is because if we want to reach a future desired state of health equity, we can't focus on healthcare alone, but there are so many community needs and that we also have to kind of dig into and make sure that our patients have access to. So this will be a great place to start and kind of assess what they're doing at the community level as well. And then just 2 more here. So the next step would be to incorporate health equity objectives into research. And what we have done, particularly at Cleveland Clinic, is to leverage learners at our institution. So we have so many pharmacy residents at our main campus, upwards of 30, and they each have to complete research projects. So it could be simple to encourage or submit projects that have health equity objectives yearly for your resident learners. But if you're an ID physician, perhaps even your medical residents could reach into that too and kind of dive into those opportunities. But before leveraging learners at your institution, you'll have to promote and advocate for preceptor development on the importance of health equity and health equity research. Just because if your preceptors aren't aware of the importance of health equity, it might be hard for them to precept the learners there. So if you can have any educational opportunities for health equity and promoting that, that would be great. And then last but not least, would recommend utilizing health equity tools. So there are 2 out there that specifically can help identify neighborhoods that have great areas of disadvantage. So this is the social vulnerability index as well as the area deprivation index. I will say that Cleveland Clinic is an Epic hospital, and we have been able to use the ADI pretty seamlessly with our electronic medical record. And then the World Health Organization also has a health equity assessment toolkit. This is more of software that's available that can help you identify, analyze, and report on health equity disparities. Okay, and finally, I have to implement your initiatives that you kind of come up with based off of your findings to help reduce your health disparity at your institution. So creating initiatives based off of your findings, that's going to take the work of all of the experts within your task force from various fields. So that multidisciplinary collaboration there. Conduct pre and post research studies. So once you kind of understand what your initiative is going to be, seeing how successful you are with that, and if not, going back to the drawing board and reevaluating your initiative. Keep your key stakeholders informed of your progress and your results. They are key and crucial and have various resources that can help you along the way. And then finally, publish your data because there's limited data in the space, and there's a call for additional research if we want to essentially reach our future desired state. So in general, overall, social determinants of health, they're crucial. More research is needed in the area of how they can be associated with health disparities, particularly in our field of antimicrobial stewardship. There's emerging literature that describes health disparities in ID, but I think that in order to kind of move from some of those individualized interventions to more midstream community and hopefully upstream interventions, that hopefully incorporation of task forces such as HEAT or the Health Equity Antimicrobial Stewardship Committee can help us achieve this future desired state of health equity. Okay, so that is all that I have. I know they were way over time.